Hello everyone. In the last video, I discussed congenital lip, pit and fistula, which are developmental disturbances involving lip and palate. In this video, I'll discuss another disturbance, that is Cheilitis Glandularis. So first thing is introduction. It is an uncommon and inflammatory disorder of the lip. It is characterized by progressive enlargement and eversion of the lower labial mucosa, and that result in obliteration of the mucosal vermilion interface. It mainly affects the lower lip. In the picture you see the lower lip or the lower labial mucosa is swollen and it everted, and the labial mucous membrane is secondarily alterated by environmental influences, and it leads to erosion, ulceration and crusting. In the picture you see there is some crusting in the lower lip, and this cheilitis glandularis can be a potential predisposing factor for the development of actinic cheilitis and squamous cell carcinoma. So next is etiology of cheilitis glandularis. What are the positive factors for cheilitis glandularis? First is actinic damage. It is also called as sun damage, that represents the skin changes due to excessive sun exposure. Okay, that is the sun damage or actinic damage. Or syphilis, that is a bacterial infection. Then it may be due to heredity, any trauma, tobacco use, poor oral hygiene and self-inflicted biting. The patient may be self-inflicted bite, that they bite their own lip. Then drying or dry mouth because of the most commonly mouth breathing habit. Then clinical features. In 1870, von Waldman introduced the term cheilitis glandularis. He described it as clinically distinct, deeply suppurative, chronic inflammatory condition of the lower lip. Then in 1914, Sutton, he proposed that the characteristic lip swelling was attributable to an enlargement of the labial salivary glands. After Sutton, in 1984, Swirlich and Cooper, they reported there is no evidence to support the salivary gland involvement. The clinical complaints, it may vary according to the nature, degree of pain, the enlargement and loss of the elasticity of the lip. It may vary, and there is asymptomatic lip swelling. Okay, there is a swelling of the lip, but it is asymptomatic. Patient may complain of burning sensation in the vermilion border, and this is associated with atrophy, speckled leukoplakic change. There is both red and white patches, erosion, flank ulceration with crusting. So cheilitis glandularis, it may be a potential predisposing factor for dysplasia and squamous cell carcinoma. So the risk of dysplasia and carcinoma that increases with age factor, especially in fair skin individual and with sun damaged skin. Next is classification. So cheilitis glandularis had historically classified into three categories. First is simple type, second is superficial type, third is deep type. In simple type, there is multiple painless papular surface lesion with central depressions and dilated canals. The lesion is painless and papular, that means some elevated surface lesion is seen. In second category, that is a superficial type, it is also painless and indurated swelling of the lip. Indurated means there is thickening and hardening of the soft tissue. The lip will be hard with shallow ulceration and crusting. Then third is deep type. There is deep seated infection with formation of abscess. There is formation of pus and there is involvement of sinus tract, fistula and potential for scarring. So the last two, superficial type and the deep type, these two categories are more potential to dysplasia and carcinoma. Then histologic finding or microscopical features. Lip biopsy is indicated to rule out any granulomatous disease and that predisposes to the lip enlargement. Okay, to rule out the granulomatous disorder, you have to take a lip biopsy. After the biopsy, you see there is a surface epithelium and beneath the connective tissue. In the connective tissue, you see several submucosal salivary glands. The minor salivary glands may appear normal or may appear abnormal. So the changes in the minor salivary glands like atrophy of the acini, ductal ectasia with or without squamous metaplasia, and there is presence of chronic inflammatory cells. Sometimes there is suppuration and sinus tract can also seen in bacterial infection, and other histological findings may be seen like your stromal edema, hyperemia, hyperkeratosis and erosion or ulceration of the epithelium. So next is differential diagnosis for Cheilitis glandularis. Those are actinic keratosis, atopic dermatitis, Cheilitis granulomatosa, sarcoidosis and squamous cell carcinoma. Then treatment plan for Cheilitis glandularis. First is antibiotic therapy. In case of acute or chronic suppuration or there is any bacterial infection, we should provide a antibiotic therapy. Or the treatment varies depending upon the patient because the clinical complaint also varies from patient to patient. Then biopsy is recommended to rule out any actinic cheilitis or any squamous cell carcinoma. So these are all about Cheilitis glandularis. I have discussed the introduction, clinical features, histopathological features, etiological factors and treatment plan for the Cheilitis glandularis. So the next developmental disturbance that affecting the lip is Cheilitis granulomatosa. That I will cover in the next video. Hope you like this video. Thank you everyone.